All right. Well, everyone, we'll get started with the last AMSSM ultrasound case series presentation of the fellows calendar. So once again, as we've been kind of doing throughout the case series, been trying to promote the AMSSM Library of Sports Ultrasound Pathology. So once again, this is a great opportunity to take pathology you see in clinic, training room, or even on the sidelines and actually turn this into a publication. So once again, the AMSSM Sports Ultrasound Committee is still looking for both common and unusual pathology related to sports medicine, and is really a great way for trainees, such as residents and fellows, and even staff, to add to the growing series of the Library of Ultrasound Pathology, and also get a peer-reviewed reference for your CV. So more information can be found under the AMSSM webpage, or you can also always email Josh Romero. Otherwise, then now introduction for our speaker today. This is going to be Dr. Brandon Hassid. He's currently a PM&R Sports Medicine Fellow at the New York Presbyterian Columbia Cornell program. He completed his undergraduate degree in exercise biology at the University of UC Davis, where he worked as a student athletic trainer and a personal trainer. He then completed his medical school at the University of Maryland and residency in PM&R at UC Davis, where he served as chief resident. After fellowship, he will actually be returning on to UC Davis as a sports medicine faculty, including serving as an assistant team physician for UC Davis athletics. And today he's going to be giving a lecture on neurogenic thoracic outlet syndrome.
Awesome. Good morning, everyone. Thanks, Dr. Schaff, for the introduction. Just going to share my screen here. All right. Can everybody see that okay?
Yep, that looks great.
Perfect. Well, thank you for the opportunity to present today. Today I'll be talking about a case of neurogenic thoracic outlet syndrome. Before I start, I want to thank a couple people who have been instrumental in this process. Dr. Jennifer Sue, who is my program director here at Columbia Cornell and has been an amazing source of knowledge and mentorship this year. Dr. Chris Visco was an important part of this case, but also teaching a lot of our ultrasound curriculum this year, and I would not have the skills that I had without him. And then Dr. Kuntal Chowdhury, who's my co-fellow. Thanks for letting me scan your neck and everything else this year. I really appreciate it. So with that, I'm going to jump into the presentation here. In terms of our objectives, we'll talk about a little bit of anatomy of the brachial plexus, talk about a standard diagnostic ultrasound evaluation of the brachial plexus, and then demonstrate some abnormal ultrasound findings that we'll see in neurogenic thoracic outlet syndrome, and then we'll talk about the ultrasound report of that. Thorough knowledge of the brachial plexus is an essential prerequisite to being able to scan the plexus, obviously. It's very complex anatomy with a lot of anatomic variation, and so understanding that is essential to really being able to perform a true diagnostic ultrasound. Jumping into our case, this is a 29-year-old male. He's left-handed, and he's a former college baseball pitcher. He was referred for ultrasound evaluation of 10 years of left upper extremity paresthesias that radiated from his left shoulder to the medial elbow and hand. Symptoms were worse with reaching overhead and behind his back, and he had increase in symptoms with throwing, particularly in the late cocking phase. Physical therapy was somewhat helpful, but not completely so. And then previously, he had had an MRI brachial plexus, as well as EMG and nerve conduction studies, which were all normal. And then an MRI of his cervical spine had minimal changes to explain his symptoms. His exam from a C-spine and shoulder standpoint was unremarkable. Some of his thoracic outlet provocative testing, including Roos and Adson tests, were positive for his index symptoms. And the costoclavicular test reproduced his index symptoms as well as a mild decrease in the left radial pulse. He had a negative Tinel's at the elbow, and then had a normal strength and sensory exam distally. So when we're doing an ultrasound evaluation in patients with suspected thoracic outlet syndrome, Obviously, we think about the difference between arterial, venous, and neurogenic thoracic outlet syndrome. But when we're thinking about neurogenic, especially thinking about the different potential sites of compression of the plexus as it comes out, particularly in the scalene triangle, the pectoralis, underneath the pectoralis minor, between the as well as between the first rib and the clavicle, and then any individual nerve compression site distally can also kind of mimic those symptoms. And then obviously evaluating the vascular structures. When we think about evaluating the brachial plexus on ultrasound, obviously going through the roots, trunks, divisions, cords, and branches. There are a lot of them, as you all remember, in the vasculature and the muscles. And then optional structures. There are a lot of branches that are probably left off the basic evaluation, but then essentially you can include as relevant. As we remember from the anatomy slide and our previous probably extensive work studying the brachial plexus back in medical school and in residency, the 5-6 roots or 5-6 roots form the upper trunk, and then the 7 root becoming the middle trunk, and then the 8 T1 forming that lower trunk, and then the rest of the plexus from there. Breaking down further here, kind of the ones that we're going to really look at here, you have the roots. C5 through C7 are the ones that you can usually consistently visualize. C8 and definitely T1 could be difficult to nearly impossible. And then sometimes you can sneak C4 in if you slide more proximally, though obviously less commonly involved in the true, more classic brachial plexus. Then you have each of the trunks, upper, middle, lower, the divisions of each, all of the cords, medial, lateral, and posterior, and then our kind of major terminal branches, median, ulnar, radial, musculocutaneous, and axillary. And then the arteries, you have the subclavian becoming the axillary artery and vein, and then some of the thyrocervical trunk and branches. And then muscles, you have obviously the scalenes and the pectoralis minor as potential sites of compression, but we're also thinking about the distally innervated muscles for each of these the same way we would in electrodiagnostic testing, and that can give us valuable information. The optional structures here that I've listed include some of just the other potential entrapped nerves that may cause various symptoms. When we think about the brachial plexus ultrasound, we think about distribution, or kind of it's a kind of a long segment, so we're going to have multiple different sites. So we'll start supraclavicularly, moving for clavicularly, and then down to the branches with the axillary and beyond. Starting with the supraclavicular, in terms of our equipment, we're going to use a high frequency linear transducer. That should give us enough depth, but more high resolution for the nerve structures, which are often small. And in many cases, we'll alternate between the linear transducer and the hockey stick or small footprint linear, just depending on the depth and kind of what we're trying to visualize. So in terms of the supraclavicular evaluation, starting with the patient supine, the neck will be neutral to slightly contralaterally rotated with the arm at the side. When we think about the anatomy here, looking at the cervical vertebrae, there's kind of one of the important things to note. Martinoli and all have described a technique to identify the nerve roots as they exit from the neuroforamen based on the anatomy of the tubercles of the transverse process. And that's what we'll use here to kind of talk through identifying which nerve root we're looking at. So here, that's kind of to what we think about as we're looking at those. And then just reminding ourselves of the brachial plexus anatomy, at least in the classic sense. Here's the anterior scalene and then the middle scalene, classically with the C5 through T1 roots coming out between those, as well as the subclavian artery, and then the subclavian vein passing anteriorly to the anterior scalene, at least in the most common anatomic variation. To start the scan, this is something that I've found and Dr. Visco has taught me, which has been very helpful, is essentially scanning kind of quickly back and forth to evaluate, to allow us to quickly move through the plexus to identify our landmarks. So starting with this, let's see if we can get this video to play. It doesn't want to do it with my laser. Here we go. So in this case, we're scanning from distal to proximal, so from the distal clavicle up towards the head. We're going to see anterior on the left side of the screen. So this will be the anterior scalene, and then the middle scalene will be here. We're going to see the nerve roots passing in between here, and we'll see starting at the bottom when this loops C7, C6, and C5 coming back. This is just kind of as you scan back and forth, you can get a nice lay of the land to start with. And when we move to the next slide, this is from a different patient, but it was a little bit of a slower clip. Sorry, it's flipped in terms of orientation, but you can see each of the nerves coming down back into the neural foramen. So we actually get C8 quickly here, C7, and then 6, and then 5 as we come here more proximally. So this is kind of our classic home base view. Let me go back to my laser pointer here. So anterior is going to be the right of our screen. This is the classic stoplight appearance. We get a C5, C6, and C7 nerve roots here in the middle, with the anterior scalene anteriorly and the middle scalene posteriorly. To get to this point, we start with our transducer in an anatomic axial plane with maybe some slight angulation. And we usually start at the level of the thyroid cartilage, which should be the level of the C5 exiting from the nerve foramen. And then we can sweep distally and proximally the way we discussed, and then using our other landmarks to help identify and get us to this home base. At this point, each of the roots is going to be monofascicular usually. So we don't get that classic honeycomb structure that we're used to for nerves. We usually get kind of mono or oligofascicular nerves at this point. And then we're going to look at each individual nerve here, starting with C7. And you might be wondering, why are we going to start with C7? That seems like a strange spot right in the middle of the plexus. But the reason is because of the anatomy of the tubercles. So posterior is the left side, anterior is the right side of the screen. The posterior tubercle is much more prominent, and there's almost no anterior tubercle on C7. And so the C7 nerve root is sitting on it almost like a little bit of a chair. This is my questionable drawing of a chair, but now you have kind of a picture of what that looks like. And can help you identify that, because none of the other vertebrae in the cervical spine kind of have that similar tubercle morphology. As we slide up to the C6 root more proximally, C6 has a more prominent anterior process. This picture is a little bit blurrier, but here's the anterior tubercle and the posterior tubercle. C5 can be a little bit more challenging sometimes, but C5 has more even anterior and posterior tubercles with the nerve root sitting on top. And then C8, there's almost no anterior and posterior tubercles. So C8 is sitting on top of almost more of a bony shelf at this point. Some patients, the C8 can be difficult to visualize and is pretty much impossible to visualize if somebody has additional or an anomalous cervical rib. So coming back to kind of our home base here, sternocleidomastoid over the top and the stoplight appearance here. Thinking about one important thing to consider, as I mentioned before, are anatomic variations. So some of the most common variations is having C5 or C6 or the upper trunk piercing through the anterior scalene, or having C8 and T1 posterior to the middle scalene. And those can obviously be sites of entrapment if a nerve is piercing through a muscle as opposed to passing around or between. Like anything else, we're going to evaluate everything in short and long axis. So starting with whichever nerve root you choose, I tend to kind of find the easiest one and then move from there. C6 here in long axis, you can see nice and linear, again, kind of monofascicular structure. And then just kind of moving through C7, and sorry for the inverse orientation, C8 here in long axis. In these long axis visualizations, like any other nerve and long axis, you're looking for any kind of focal sites of a compression, which may be indicated by narrowing of the nerve, notching of the nerve, or what we call like hourglassing, where it gets more narrow and then kind of widens back out. That would suggest a focal compression, or any like swelling that can be seen in cases of like parsonage Turner. As we slide more distally, we get towards the trunks. Again, we still have our scalenes here, and then the C5 and 6 have now coalesced to form the upper trunk. The C7 is continued as the middle trunk, and the C8, T1 have formed the lower trunk. You start to have more fascicles here as we slide more distally, and we can see the arterial and venous structures here anteriorly as well. Moving distally into the divisions. The divisions can be, as you note, I've labeled them just divisions. It can be very challenging to identify each individual division, but for a skilled sonographer with the time and patience to do so, you potentially could. Though clinically, it's pretty rare that you have an isolated individual division injury. And so if you did feel the need to dive deeper in there, you could. Before we move more distally, we're going to look at some of the vascular structures. Like we think about with like the radial nerve, sometimes you can have vascular leashes causing compression. So here we have the anterior scalene, middle scalene, our classic stoplight view. We have the subclavian artery, and then one of the branches coming off is the thyrocervical trunk. And then that quickly branches into multiple arteries, including the transverse cervical artery. The most classic presentation of this is actually coming between C6 and C7, which in this patient, actually, we have an anatomic variation where is coming more superficial to C5, but this can be an area where there's a lot of variability. I'm not going to discuss in this case like full evaluation with like Doppler imaging and looking for thrombosis in the subclavian artery or vein or axillary artery and vein, though that is something you could certainly do. So moving on to the infraclavicular evaluation, usually once we get past the divisions, we'll kind of localize our cords and follow those as distally as we can to the clavicle to try to create as complete a visualization as possible. Though a lot of times your cord visualization is going to be better distal and infraclavicularly. In terms of this evaluation, same positioning as before. Now the patient can return their neck to neutral, especially if it's getting uncomfortable. And the position will be supine. And then we're going to start in kind of an oblique, somewhere between sagittal and axial plane. And the reason we're doing that is we're going to use our pec minor as our area of orientation, at least as our point of reference. So here, we're going to start with our pectoralis minor. Laterally is going to be at where the coracoid is. Ideally, you start with your visualization over the coracoid and then slide medially. I don't have that in this image. And then you have your axillary artery, and that is surrounded by the cords of the brachial plexus. The medial cord is most medial and typically located between the axillary vein and the axillary artery. Lateral cord is directly lateral to the axillary artery. So most of these are labeled based on their orientation relative to the axillary artery. And then the posterior cord is the pseudo exception to that, though there is some variation. It may appear as if the posterior cord is actually directly deep to the axillary artery, but often this is actually just an artifact of increased through transmission through the axillary artery that suggests or gives you the illusion that the posterior cord is there, when in fact it's actually directly posterior to the lateral cord in most cases, though obviously some variation in that positioning. Your pectoralis minor is superficial to those, with the pectoralis major over the top. And then we'll kind of talk about what we see in this patient here in just a moment. You can apply additional transducer pressure to help compress the vein to help you identify what structure you're looking at. And then from here, you can slide proximally and kind of distally along this to look for any sort of sites of compression or abnormality. We'll then rotate on the cords in long axis. Here we see the lateral cord, and this kind of convinces us that the posterior cord is directly inferior to the lateral cord, as we were looking at here on the cross-sectional view. We'll then move to dynamic evaluation, and here I'll start to talk about what we see with this patient. The cords themselves don't have any focal abnormalities that we see, though the pectoralis minor does look a little bit abnormal here. It has normal echo texture. There's no signs of atrophy, though usually the pec minor has more linear appearance across with the arm adducted. And here we do see what's referred to as pectoralis minor bowing, which indicates that the proximal and distal ends of the pec minor kind of have a deepening trajectory. And we'll kind of talk about some measurements that have been described in the past. In terms of dynamic evaluation, sometimes, especially if a patient has no bowing in the adducted position, checking in an abducted external rotation position can be helpful, particularly since that is often the position that provokes symptoms, and as is the case with our patient, as we mentioned in the history. So here in our patient, we see that kind of similar morphology of the pectoralis minor, though maybe a little bit more prominence of the lateral cord up into the pectoralis minor with the arm abducted and externally rotated. So now moving on to kind of how we can measure and quantify bowing. What you do, this is a technique described by Dr. Suture and all back in 2012. You basically draw a line from the kind of the base of where the pec minor inflection is, and that is referred to as they refer to it as AA in their paper, and then drew a kind of vertical line from that line to the apex of the pec minor convexity, and called that BB, and then calculated a ratio of those, and then expressed that as a percentage. And in their report, 17% in their case series was what the average value in patients that were symptomatic for neurogenic thoracic outlet syndrome, and then the average patient without symptoms had basically a bowing ratio of approximately like 2 to 3%. Here's a comparison of a normal patient on the left to our patient on the right. So you can see that more linear pectoralis minor structure and morphology is composed as compared to this kind of bowing picture here on the right from our patient. I don't have exact measurements for our patient here or for this other one here, but you could visually see a significant difference. Moving distally into the axillary evaluation and beyond, I've drawn here kind of your start point for the axillary evaluation, which is where we'll look at this initial kind of home base view, and moving distally, though often it's actually easiest to evaluate each nerve by finding it at a more obvious site that you're familiar with based on each distal evaluation, and then following it back up to kind of convince yourself that the nerve that you're looking at up in the plexus is actually the nerve that you're thinking of. So same positioning, slight abduction of the arm, though you can kind of vary that between all the way up to like 90 degrees. And then if you're doing specific maneuvers for each individual distal branch, you can position accordingly. So orienting here for our axillary position, starting with our axillary artery right here in the center of the screen. We'll have our kind of nerve branches around. So you can see the median nerve here, kind of superficially and posteriorly, the ulnar nerve, and then the radial nerve, but more posteriorly here. The musculocutaneous nerve is often between the short head of the biceps and the coracobrachialis here, though this image doesn't capture it terribly well. Often kind of some dynamic scanning back and forth, like in the initial stage, can help you identify which nerve that you're looking at. These nerves do have kind of a classic positioning, though obviously like everything else, turning into a broken record here, talking about anatomic variation, but it is important to note the ulnar nerve, kind of at least the way that this is oriented classically in this kind of like 10 to 11 o'clock position, with the radial nerve in that more 6 to 8 o'clock position here, and then the median nerve in a more 12 to 3 o'clock position. And then you may see the medial antebrachial cutaneous and lateral antebrachial cutaneous nerves branching off here as well. So then we can follow each individual branch down here. In our patient, these are all normal evaluations, so I'm not going to spend too much time here. but finding your median nerve and short axis as you go distally, and long axis, again, looking for any notching or hourglassing, which may suggest a focal site of compression, and also changes in the fascicular architecture, sometimes enlargement or obliquity to the of the fascicles can suggest abnormality to the nerve. Same thing for the ulnar nerve here. We follow this particularly in our patient because he was having symptoms in digit 4 and digit 5. We followed that all the way through the retrocondylar groove, which is not pictured here, just to ensure that there was no focal compression or enlargement or swelling. Same thing with the radial nerve. We see it entering the spiral groove here in the back of the humerus. This was normal in our patient as well. Lastly, moving on to the axillary nerve, this is the one that has different positioning than those other ones. Here we're going to look at this posteriorly, the most common site of compression being in the quadrilateral space. So here, proximal is to the left side of our screen. This is kind of the posterior aspect of the humerus here. It was our teres minor here in short axis, and our long head of the triceps coming over the top. Here we can see on Doppler imaging our posterior circumflex humeral artery, and so we can identify that with the axillary nerve coming through the quadrilateral space. And that was the extent of what we evaluated in this patient. As I mentioned before, if the patient were having distribution of symptoms in any other particular nerve distribution, we could evaluate any of those associated nerves. Lastly, I think it's important to look at the muscular evaluation, both comparing potentially side to side as well as to adjacent muscles, looking for any sort of abnormalities which may suggest a neurologic issue. Most commonly, we think of changes in echo texture, both like fibrofatty infiltrate, as well as any sort of atrophy or changes in size of the muscle, which may suggest a neurologic issue. And then kind of like in electrodiagnostic testing, you kind of put together your whole picture. If you see brachial, or if you see abnormality in all of your C6 muscles, but not in others, that may suggest certain pathology versus a peripheral nerve lesion, for example, in some median nerve muscles. Moving on to our diagnostic report. This one can be kind of a lot because we identified a lot of structures. So sorry for the busy slide here. But like any other presentation, we're going to have our, kind of our, what are we examining? What is our indication? And then who our sonographers are, and then when the date of the study was, and then indicating our findings based on each individual structure. In this patient, we talk about the muscles all being normal in appearance, the neuroforamen and the nerve roots, no abnormalities. The interscalene triangle, when we looked at the trunks, there was no abnormalities or signs of compression. And then with the supraclavicular evaluation, looking at the divisions and then the cords in the infraclavicular region, this is where we note our most notable finding in this patient, indicating that there is bowing of the left pectoralis minor muscle over the trunks, and then dynamic evaluation with the arm in abduction and external rotation. It demonstrates slightly increased bowing of the pectoralis minor muscle. If we had performed a calculation in this patient, that would be a good place to include it. And then moving into the axillary evaluation, the transverse and longitudinal views of the different branches were normal in this case. And then same thing with the other distal nerves. Moving into our impression, bowing of the left pectoralis major or minor muscle over the trunks of the brachial plexus, which slightly worsened with abduction and external rotation of the arm. And then the remainder of the ultrasound examination was normal. Other things we could potentially include here would be indicating that that can be seen in patients with neurogenic thoracic outlet syndrome. I'm not going to go into kind of the different classifications of neurogenic thoracic outlet syndrome in depth, but it is important to note kind of the classic description of true neurogenic thoracic outlet syndrome, which has either findings on imaging of any sort of nerve abnormality or electrodiagnostic changes, versus kind of suspected neurogenic thoracic outlet syndrome, which is kind of basically the clinical presentation without those abnormalities. There's been another kind of terminology that's been thrown around more recently, including like postural neurogenic thoracic outlet syndrome, where we don't necessarily see those anatomic or electrodiagnostic changes, but the patient only has symptoms in certain positions. But those are important to note as you're kind of moving through diagnostically, and maybe as we get a little bit more research further defining these in the future. I know that the scope of this lecture is not so much about the treatment of this, but I just kind of, for completion's sake, I wanted to walk you through what we ended up doing for this patient and how he's doing. He initially received an ultrasound guided pec minor injection with just lidocaine, which gave him a pretty significant improvement for several days, but then wore off. He had a surgical consultation for pectoralis minor release, who recommended repeat plus or minus Botox or scalene injection. We ended up doing the scalene injection, which was somewhat but less helpful than the pec minor injection. So he had subsequently kind of two pec minor injections after that. At that point, we had proceeded to try botulinum toxin, which actually helped in terms of his scapular motion and a lot of his kind of symptoms on a day-to-day basis, though he did have some D4 and D5 tingling still. So even though there was no abnormalities because he was having persistent symptoms, we did do a hydrodissection at that level, which gave him some relief temporarily from that. And then most recent follow-up was actually last month. He reported he was fully functional in daily activities, but he had not quite fully returned to overhead activities. He's now 29, so he's not a pitcher anymore, but just kind of his all day-to-day exercise program is still a little bit modified. But he's continuing some physical therapy to work on kind of that pectoralis minor mobilization. We did do a repeat ultrasound examination of him just about a month ago. You could see that pectoralis minor bowing has actually significantly improved here. Though when you do bring him up into abduction, you do see a little bit of that bowing still in this case. So not quite fully resolved, but we are much closer to kind of a normal appearance there. To wrap up, just a couple of take-home points. I think it's important to have detailed knowledge of the anatomy and the anatomic variants of the brachial plexus so that you can understand what is normal and what is abnormal, because there's a lot of structures and variability. So being careful about not overcalling something when it's really just an anatomic variant. And then correlate and guide your ultrasound evaluation with your physical exam. And then with any nerve ultrasound or even MSK ultrasound, but especially in the brachial plexus, rapid back and forth scanning kind of proximal to distal can really help you orient and identify your structures, particularly with nerves. And then the one other thing that I've learned is that considering MRI of the brachial plexus, whenever you're doing an ultrasound of the brachial plexus, to make sure that you're not really missing anything. Often the patients can have, like anything else with ultrasound, we have limitations, including the depth as well as our ability to visualize through bony structures, particularly the clavicle. And one of the things that we definitely, would often miss with an ultrasound, if that were our isolated imaging, is a Pancoast tumor in the kind of upper portion of the lung, compressing the lower trunks. So Dr. Visco and I have talked about this, and his practice pattern is often, if he's doing a brachial plexus scan for ultrasound, especially if he sees nothing, but often in pretty much everybody, he's going to order an MRI of the brachial plexus to make sure that we're not missing anything deep to what we can see with ultrasound. And then obviously the C-spine is a common cause of symptoms that are similar, and so making sure that you evaluate for other things on your differential diagnosis, not just locking in to thoracic outlet syndrome, which is usually lower on the differential anyway. Here's a couple of the references, and then with that, I'll take any questions and comments.
All right. Wow, Brandon, that was a phenomenal presentation. You and Dr. Visco definitely make this complex scan look simple. So honestly, I don't really have too many separate points to make, but just a couple of things I think to be helpful to just reemphasize. Obviously with the scan, it's for a lot of the providers, it's going to be fairly infrequent. And obviously just based on the anatomy is going to be pretty intimidating, to kind of begin with, just because of the complexity as well as the variants and things like that. So as you had mentioned, obviously just, going first and foremost, just having a good basis of the anatomy knowledge going into this. especially when you're going from supraclavicular to the infraclavicular, region. But just like any scan, and really kind of the emphasis for the series as well too, I just really appreciate you're kind of very protocol driven and then kind of using home bases for this. And so one thing that I definitely think can be helpful with this scan is that, yeah, when you start out kind of taking a look at those roots, is just using the tubercles, as you had mentioned, for C5 and C6, which will both have those anterior and posterior tubercles. And then just knowing that C7 is really just going to have that prominent posterior tubercle. And that can be kind of just a helpful, starting point to feel comfortable. Okay, this is where I'm starting to look at for C5, C6, and then C7, and then continue to follow those down to the scalenes. And then obviously, distal as you go to each of those regions. I think it's just a really good starting point and an area that you can start to kind of practice. So you start feeling comfortable at the beginning of that scan. I think you had kind of highlighted the two major areas for, pathology that we're going to see throughout this scan. Is going to be obviously at the scalenes, but as well then too at the pec minor. And I think we're finding for a lot of these, cases, especially for the overhead athletes, that it is, possibly truly more related to the pec minor than we were, realizing. And as we had highlighted, that you're starting to see some of that kind of bowing of the pec minor, which can be pathologic for this. And then obviously, for these scans, you have your kind of traditional positioning that you're going to have. But then also, adding in the dynamic maneuvers that you already might be doing on physical exam, just to see if there are, changes, in that region that also do reproduce the patient's symptoms. And something like this, as you had always noted, it's very easy then to do a contralateral exam to compare side to side, especially if you're starting to get beginning with these scans, which sometimes can make that pathology look pretty evident, as your kind of pictures, demonstrated here. And lastly, you'd kind of talked about the treatment plan and things like that. And obviously, this isn't the major, scope of this series, but diagnostic injections are obviously going to be a huge supplement, in this region to your diagnostic, scan of doing those, either at the pec minor and scaling. But obviously, starting to feel comfortable with evaluating, those structures, before starting to do injections. But obviously, that can be helped to confirm, pathology and truly what is the main primary pain generator for these patients in that area. So once again, just a bunch of points I think to reemphasize, but this was just, I think a phenomenal, presentation for an area that, we really haven't kind of had as much like protocol, driven information on. And this really kind of, I think, hit on all the points that I think will be helpful. So thanks again.
Yeah, thank you. And then thanks for the additions. I think the dynamic component is important, especially with everything else. We often are trying to correlate both our exam and our to the patient's symptoms as well as with ultrasound. So doing things like sonopalpation, especially with like nerve compression distally. Though a lot of these patients, kind of with that abducted external rotation positioning that we do for the dynamic evaluation, if you spend maybe a couple minutes there, and even when you're doing your axillary evaluation, keep them up there. A lot of my patients are like, can I put my arm down? I think it's reproducing the symptoms even pretty quickly. So both thinking about your patient comfort, but also correlating that with the symptoms is very helpful.
For sure. All right. Well, listen, I will keep opening it up though to anyone else that wants to make any points or has any
Yeah.
specific questions.
I, this is Doug Hoffman. I just have a couple comments or questions as well. So, if you're scanning the shoulder a lot, certainly these are reach structures and it's hard to dabble in the brachial plexus, but if your practice is heavy in shoulders, I find it really useful to have some proficiency in scanning this area. Otherwise, you're limiting yourself, just to the traditional shoulder structures, but it is hard to dabble in it. And I think this presentation highlights, again, a systematic approach, finding the home base. But it is more difficult if you're starting out at ultrasound because, dynamic exam is pretty key here and keeping the probe moving to let your eye catch all these structures as well as the variations. And one other quick comment, then I have a question. The other comment is, there's many areas where, deep venous thrombosis are fairly common areas to have it. And this, of course, is one area with a Paget-Schroeder syndrome. And so I often, the other area is the popliteal space. And so it's pretty easy to look at the subclavian vein, the axillary vein, and just do a compression and quickly know right away if there's a problem. And if there is a problem, if I do identify a problem, then I will refer for a dedicated venous study. But that's another just area to think about, especially in the world of sports medicine. Hey, Chris, are you still on?
Hey, Doug.
Yeah. So I want to tap into your experience with this. In your experience, what is like, I don't do a lot of brachial plexus, but the biggest pathology I've seen are people with ORIF of the distal clavicle and then, abrasion to the plexus. But in your experience, because your practice is heavy in this, what are the one or two most common causes that you see in neurogenic outlet syndrome?
Well, the probably the single most common cause of neurogenic thoracic outlet is a concurrent systemic etiology of nerve-related pathology. So, for example, someone has an infectious or other etiology, which resulted in some, swollen nerves, essentially, for, lack of a better term at this second that I'm speaking, and or parsonage Turner type of symptom with concurrent neurogenic thoracic outlet. That's, I mean, it's probably pretty darn prevalent out there that people have some small component of this concurrent with their disease or disease onset that we kind of chalk up to other things, and it gets missed. Now you don't always see it, but for a comparison to the other side, so which is why that side-to-side comparison is important.
And so,
The next, yeah, go ahead.
I'm sorry. So in your experience, if you clinically say, well, I think someone has a Parsons-Turner syndrome, do you feel that, detecting swollen nerves, like with side-to-side comparisons, is a fairly accurate ultrasound finding, or do you find it hit or miss?
It's very hit or miss because it's going to be determined based on the length of time from the pathology, the persistence of pathology, and the severity. And all those things need to be considered. If somebody has a very severe lesion and there's been and you're also very close to the time of pathology, you might see nerves that look pathologic that aren't even affected, and clinically. And so you always need to take these things into consideration. The single best piece of advice that was given to me was by Carlo Martinoli. I was teaching with him. Doug, you were probably there. I was teaching with him at the Mayo Clinic with probably you two one of these years when the Mayo course was still going on. And we leaned over and I said, well, when should I scan the brachial plexus? And he said, everybody. You scan everybody. Scan every single brachial plexus that you can, even when you don't have a brachial plexus pathology, because you need to get your eye tuned to what a typical brachial plexus looks like, and you need to get accustomed to looking at these. So you scan everybody. And it was a great piece of advice. That's what I would recommend, because even though we're not going to see brachial plexus pathologies walking in, they're not going to sort of be referred specifically for this. You need to get accustomed to what the range, and I think Brendan did a wonderful job of telling you that range is going to be wide, what the range of normal is. So it is very difficult to pick up, briefly, to answer your question.
Awesome. Thanks for the input and the question, Dr. Hoffman, and Dr. Bisco as well for your clinical expertise. Anybody else have anything else to add?
Yeah, I don't see anything else in the chat so far. So I think this will go ahead and end the presentation today, as well as then the fellow presentations. So once again, thank you to all the sports medicine fellows that have given presentations this year. I think they've all been phenomenal. Looking forward to you guys all continuing to contribute in the future as attendings. Congratulations once again to all the fellows graduating as well too. So like I said, this is going to conclude the fellows ultrasound case series presentation component of it. We now will be taking a little bit of a break for about the next month and a half, and then starting on August 2nd, we'll be beginning the faculty and staff presentations again until December.